start with this nice session on cardiogenic shock. I am Gabriella Bottari from Children's Hospital Bambino Gesù in Rome. It's a pleasure to introduce my co-chair, Diamanto Areta from Patras University in Greek. So we can start with the first speaker, Anthony McLean from the Sydney University. Please, Anthony, give us your lecture.
Thank you for the opportunity, and that's right. So I'm going to talk about Takotsubo syndrome, and what a fascinating syndrome it is, and it has sort of a magical quality about it. And first of all, I have no conflict of interest. And in fact, a long time ago in a faraway land, this story comes about where there was an earthquake. There was the recognition of patients who had cardiac dysfunction with a particular pattern, and that particular pattern would reverse over time. And then we look back with a certain amount of mystical wonder on the syndrome of Takotsubo cardiomyopathy, as it was called then. But I'm proposing in the next short while to try and convince you that, in fact, all reversible myocardial depression should be called Takotsubo syndrome. This is just an example on the left-hand side, a woman who'd been found on the floor unconscious. She'd been there for 24 hours. You can see the apex is not contracting that well, and a few days later, in a woman who has normal coronary arteries, it's now contracting very well. And this is a classical example of the classical Takotsubo picture. So let's just go back, though, and have a look. By 2011, this is the number of terms that were already in use. Now, we're talking over 12 years ago, and by Sharkey, who's a well-known researcher in the area. And by then, these are all the terms that we were using for parts of the muscle and the heart that were not ischemic damage, but were reversible myocardial damage. And as you can see, the list is endless, and in these days it would be even longer. So even 12 years ago, we were actually rather confused as to what we were talking about. So let's go back and say, well, what were the Japanese talking about when they talked about Takotsubo cardiomyopathy? And in fact, this is one of the first publications, which was in 1991, and they talked about 5 patients. 5 patients. And in those 5 patients, the main finding, in fact, was that there was reversible myocardial depression in the apical, diaphragmatic, and the anterolateral segments. And, in fact, in that group, it showed that there was spasm in the arteries caused in 2 of the patients. So basically, already we had only 5 patients. It wasn't quite clear that it was the apical abnormality or the abnormalities were elsewhere. So if we go back further in time, in fact, the first reported case, in fact, was in 1982. In 1983 in Hiroshima Hospital, and this is a courtesy of Temple, who's a Swiss researcher in the field, and he obtained this paper from the original author, and this was the classical Takotsubo syndrome. Here's the Takotsubo octopus net. So by 2001, of course, these case histories had come to prominence. So there was an accumulation of 88 patients in this study in 2001. These are all Japanese. But let's just look at these patients. Only 24 patients, or 27%, had emotional or physical problems as a cause. The other people, in fact, had things like preceding aggravation of underlying disorders such as vascular accident, epilepsy, lung disease, etc. So already it's becoming blurred that the classical Takotsubo syndrome was never really a classical syndrome in the first place. Of course, this was a pivotal publication, and this was in the New England Journal in 2005. And this was Wittstein's publication of a number of people who in fact presented to a New York hospital who had reversible myocardial depression all due to emotional stressors, and I've just put the list of emotional stressors down there on the right. And in fact, these people had reversible myocardial depression. But really what happens in this group is that around the turn of the century, we ended up having mobile echo machines available. We ended up having a lot of workshops around the world training critical care doctors how to use this machine. This is one from Vietnam. Last year we were involved, but this is just one example of a training program. And so, in fact, in the critical care setting, we were now looking for this. Before that, you had to do angiograms, in fact, to look at the reversible myocardial depression. And by 2002, as you can see already, we'd found in all these conditions in an ICU and a lot more, and I'm sure many of you in this audience have encountered it, somebody with pancreatitis who has reversible myocardial depression, certainly sepsis-induced cardiomyopathy it's called, and all these other conditions. Now we're aware there's a whole range of conditions that cause reversible myocardial depression. And so let's fast forward now to 2018 in an attempt to bring all this together and say what on earth is Takotsubo syndrome. There has been a group of the Intertac diagnostic criteria. This is a group of international experts, and basically what they talk about, these are the diagnostic criteria for Takotsubo, and we call it Takotsubo syndrome. Now, the change from Takotsubo cardiomyopathy to Takotsubo syndrome is, in fact, there is no actual cardiomyopathy in these patients, because when the reversal of the abnormality occurs, the muscle is quite normal. Hence the term Takotsubo syndrome. And I'm just not going to go through all those at the top to say, except there's a whole range of segmental wall motion abnormalities, just not the apical one. And the most important change here, and there's obviously a lot of important ones, but there's this one here, which is to say there didn't have to be absence of coronary artery disease. Now, this is important because before, and we all know when you've got apical akinesis, have we got an occlusion of the left anterior descending artery, or do we have Takotsubo syndrome? Let's do a coronary angiogram. That'll help us sort it out. But in fact, it was originally said you had to have normal coronary arteries, whereas it's now stated you can have coronary artery disease and it can be significant. It's not necessarily a contradiction to Takotsubo syndrome. Now, when you think about it, that makes sense because we've all dealt with patients who have had an out-of-hospital cardiac arrest. They come into your intensive care unit. Some of them survive, but they may come in with a poor left ventricle and ejection fraction, say, of 15%, but at the time they leave your ICU, their ejection fraction might be 30, 35%. Sure, they might have had a myocardial infarction. They may have infarcted some of the myocardium, and that is now not contractile tissue, but you also have other reversible parts of the ventricle. So that is a major change in the diagnostic criteria. This is just an example of a 41-year-old woman who, in fact, had a dyspnea, had sepsis, and I'd just like to point out here, this is just a case of reverse Takotsubo syndrome, where in fact you had akinesis of you can see the inferior wall there, which after a few days' time comes back to normal. And so now this is the chart that goes with it. Reversible myocardial depression, or Takotsubo syndrome, we now have a range of causes, both down the emotional triggers and both down the physical triggers. And so you could say anything that causes reversible myocardial depression should fall into this group. ECG, well, we've known for some time the ECG pattern doesn't really help us differentiate from Takotsubo syndrome and acute myocardial infarction. Here's an example of one person, an ECG here with a lot of ST elevation. 10 hours later, that's completely gone, and we have a lot of T-wave inversion. Here's another one with arrhythmias, and we are aware that, in fact, there's a whole range of ECG patterns that you get with Takotsubo syndrome. They can mimic an acute myocardial infarction, or they might be quite non-diffuse changes and don't have any pattern at all. So that hasn't been particularly helpful. In addition, I haven't put in here about serum troponin, but we know troponin levels are much the same as well. You can have very high troponin levels in either acute myocardial infarction, but you can also have it in Takotsubo syndrome. This is just another case here of a just to remind ourselves that we were always talking about the left ventricle, but it became apparent, and once again, this is with mainly critical care physicians doing echocardiography regularly in their units, that in fact you can, it's probably not that clearly seen, but this person has Takotsubo syndrome on the left, but also the apical part of the right ventricle is also markedly impaired. And so we know that it's just not the right, it's also the left ventricle that is involved in Takotsubo syndrome. We shouldn't underestimate it, however. Takotsubo syndrome has a considerable mortality, and there is a prognostic score. Once again, this is by the Intertac group, where you can put together a score here from your whether it's secondary to other conditions, and this is a point I'll come on to in a moment, whether it's secondary or primary, age. I won't go through the list here. You get a score, and if you end up in this purple range here, which is the most severe, you can see that your mortality over the coming years gets up to 60 to 70%. So it is not a condition to be ignored, and even in the low risk group, you can see the mortality increases as it does with more points throughout the year. So Takotsubo syndrome is just not a one-off thing. You often have to ask why it happens, and of course I'm sure some of you have come across the patients who've had Takotsubo syndrome in the past. No obvious trigger, perhaps apart from emotional disturbance, and they can have it again sometime in the future. So in the intensive care unit, of course, it's often a case, there's all this debate, you're doing a ward round, you're looking at the patient, you see the echo, and you have to ask, does this person have Takotsubo syndrome or not? And this is just a publication in combination with Michelle Slummer and Michelle Chu, who I notice is speaking later in this session. I'm not going to go into the pathophysiology, not to say it's not interesting, but the reality is the pathophysiology is not clearly identified. There's been a lot of work to suggest it's, whether it's the change in the sensitivity of the beta-2 and beta-3 receptors in the heart, or whether it's catecholamines, etc. Let's just say it's interesting, but the jury is still out. There's a lot of hypotheses, and this is just one from the intensive care group, Singer and Hollenberg some years ago, that look at whether it's mitochondrial dysfunction, systolic function, etc. So there's a lot of thought, there's a lot of interest, there's a lot of conjecture, but we're not actually entirely sure in 2023 what is the exact etiology, the exact cause, I should say, or mechanism by which the myocardium becomes hypocontractile. I have to say there is a tendency to believe it is a protective thing that the heart does. It's actually not a pathological negative thing. It may well be a protective thing for the heart to sustain the heart during a particular difficult period, which is one theory I have to say that I find particularly attractive. Of course, this is a discussion on session on cardiogenic shock, and it was always assumed that once you had coronary artery disease that you had to rule out Takotsubo syndrome. But as we can see now, the rules have changed, and you can also have coronary artery disease and have Takotsubo syndrome. And this is just one paper from a group that suggests that perhaps it's, as they say, different sides of the same coin. It's all to do with supply and demand of the oxygen, and there's just a difference in the amount of the supply and the amount of the demand, but essentially it's all sort of some form of ischemic stunning. So you can see how they merge together. So Takotsubo syndrome is the evolution of diagnostic terms. If we're talking about it in 2003, You can feel quite comfortable using the word Takotsubo syndrome for septic cardiomyopathy. Some of the diehards say septic cardiomyopathy is a different animal. It's not really, it's just part of the whole process. It's a syndrome, as I mentioned. It's not a cardiomyopathy. The stress can be anything. It can be emotional, which is the classical description of it, but can also be physical, and it was from the start in the 1990s when it was first described. The wall motion abnormalities are varied, just not apical ballooning. It's left and right ventricular involvement. There's a variety of ECG changes and so on. So why not just call it Takotsubo syndrome? And I just might finish with this last slide. And my recommendations in summary is that we should use the word Takotsubo syndrome for reversible abnormalities of cardiac pump failure associated with critical illness. We could call it as a primary one if there's only cardiac involvement, or secondary if we have other conditions such as sepsis or pancreatitis and the like. And so that helps us separate it from the single ones the cardiologist sees in the emergency department following an earthquake, as opposed to those of us we find it in a patient who's had pancreatitis, but in fact has now developed it. And unlike that, I'd thank you for listening.
Thank you. Question from the audience? We have time for a couple of questions.
No questions?
May I ask a question? What about the therapy? Is there any specific evidence to protect myocardium, which some drug? What about the therapy?
Sorry, what was that again?
The therapy. If there is any evidence about some protective therapy for the myocardium?
That's a very good question, and the data is not clear. However, I'll give you my own personal preference. I believe that, in fact, if you go and use therapy on these patients, you have to keep in mind that the hyperkinesis of the ventricle may be something that the ventricle wants, and if you're going to actually augment it, then use a kind inotrope. And for me, for example, I would consider levocimendin as opposed to, say, a catecholamine. Okay.
Thank you.
Thank you. And we'll move to the second author, speaker, which is Professor Alain Combes, a very famous author, from the Hospital de la Pitié, from the University of Paris. Welcome,
Thank you.
Dr. Alain Combes.
Thank you so much for this kind introduction. So I have actually a difficult task today when to do an endomyocardial biopsy in patients with acute heart failure. These are my disclosures. So first, let's have a look together at guidelines, indications. And those are guidelines recently published by the Heart Failure Association of the European Society of Cardiology. And when looking at the numbers, especially in big heart centers in which there is a heart transplant program, most of the indications for a biopsy are those heart transplant patients for rejection, surveillance and monitoring of acute rejection. The second most frequent indication is, of course, myocarditis. Well, for heart transplant, there's still a controversy ongoing because now we have molecular signatures which might be associated with rejection, which might decrease significantly the need for biopsy. But it's out of topic here, and I would like to focus now on the indication and timing of biopsy in patients with clinically suspected myocarditis. Once again, I will review the guideline and show you some data we gathered in recent months. So those are the guidelines published just 10 years ago by the working group of the European Society of Cardiology. And at that time, for those patients with clinically suspected myocarditis, first, of course, there was a need to exclude coronary artery syndrome, Otherwise, the biopsy was systematically indicated, first to confirm the diagnosis of myocarditis, and second, to identify a potential etiology and type of inflammation, especially, of course, giant cell, eosinophilic myocarditis, sarcoidosis, which may need some specific treatment and most frequently immune suppressors in these indications. So there was a wide indication here, and it has been a little bit modified in the most recent statements. This is here from the Heart Failure Society of America. Once again, a scientific statement here published in 2020. And for those patients with unexplained acute cardiomyopathy, the need for rapid biopsy was for patients requiring ICU admissions because of the need of inotropes or even heart support devices, MCS. Those patients with heart blocks, because we know from the epidemiology that heart blocks are highly associated with sarcoidosis. So it should be performed here to rule out sarcoidosis. Same for sustained recurrent VT-VF, which may indicate giant cell myocarditis. In this situation, probably also the biopsy should be performed as soon as possible, or for those patients who fail to respond to guideline-based management within 1 to 2 weeks of diagnosis. So there was not systematic here for, at least for first-line care of these patients. This is another one from a group which is highly experts also in the field. And I like this one also because it stratifies the presentation in 3 different groups of patients, those at high risk of especially death of the disease, intermediate risk and low risk. And the biopsy remain indicated for those patients with the highest risk with cardiogenic shock, and patients with the most severe forms, and including those with VT and VF. And frequently MRI is not possible, at least very rapidly, because it's probably the gold standard diagnostic tool for now, but it's, well, not frequently possible in those most severe forms who remain in the ICU or even who received ECMO, for example. It's not possible to move these patients to the lab. When looking at the latest is from now, again, the ESC, which is an update here of the management of patients with acute and chronic heart failure. This probably is now more balanced. EMB should be considered in patients with progressive heart failure despite standard therapy. And when there is a probability of specific diagnosis, we are back to those patients with VT-VF, with heart blocks, which it should be confirmed rapidly to initiate a specific treatment. So how now to perform this biopsy? If possible, once again, the patient should receive an MRI, cardiac MRI, to localize, to visualize the level of edema, necrosis, fibrosis, hyperemia, late gadolinium enhancement, because myocarditis is not a diffuse disease of the ventricle in most patients, is localized, and it might be very important to have these images before getting an EMB to be able to target the EMB to the sites which are involved in a specific patient. Should it be right or left? It's probably better if you are looking for myocarditis to perform a left ventricle biopsy. Right ventricle biopsies are mostly performed for heart transplant patients and the monitoring of heart transplant patients. Contraindications is obvious. Patients with intracardiac thrombi, ventricular aneurysm, severe valve stenosis, or those patients who have specifically aortic valve mechanical prosthesis should obviously not receive a biopsy. And there's some risk also, which may explain, as we'll see, that despite the fact that guidelines recommend biopsies close to 100% for those very severe patients, including those in cardiogenic shock, the number of patients who actually receive a biopsy is probably still less than 50% of those who might have an indication of this exam. And the risks are mostly related to cardiac perforation. Tamponade might be very limited in highly experienced centers, might be up to 7%, maybe in those less experienced centers, might be also risks of valvular trauma, arrhythmias, heart blocks. But once again, it's clearly related here to the experience of the team. If a biopsy is performed, a minimum of 5 samples should be taken, 3 for pathology, 7 for infection, mostly PCR, and if possible also some fragments for viruses, replication, RNA replication in the samples. Histology, of course, classical histology and immunohistochemistry to get more details about the type of cells involved here in the disease, both T cells, also macrophages, and the activation of HLA-DR in these cells. And the ESC also provided some threshold for all of these immune cells in the myocardium in biopsies to make the diagnosis of myocarditis. Once again, if possible, quantitative RT-PCR for the classical viruses involved in myocarditis, parvovirus B19, HHV6, the enteroviruses, Coxsackie, might be SARS-CoV-2 as well now. And if possible, although it's not that frequently positive, viral mRNA for active viral replication. And other types of bacteria and viruses might also be further assessed if needed. In patients with myocarditis, it's still the Dallas criteria, which is used to grade the severity of disease between active myocarditis, where there is both a cellular infiltrate plus signs of necrosis, myocyte necrosis, might be only borderline, when there is only a cellular infiltrate without signs of necrosis, and might be negative if there is no infiltration, no inflammation within the sample. Examine might be focal, confluent, diffuse, mild, moderate, severe, depending once again on severity. The problem is it has low sensitivity and specificity. These are 2 pictures here on the left panel of a borderline with some small T cells, small lymphocytes here within the myocardium. On the right panel, it's an active myocarditis with a huge infiltration here with small lymphocytes and also signs of necrosis. But once again, the sensitivity might be as low as 40 to 50% because most of these biopsies are blinded and you may actually miss the foci of inflammation if the biopsy is performed blinded. This is why it's important, if possible, to perform an MRI before the biopsy. Same for these large series of more than 800 patients with unexplained heart failure. In less than 30% of the cases, the biopsy provided diagnosis and changed the clinical course of the patient. And when looking at the evolution of Dallas negative and positive biopsies in terms of survival, there was no difference here. This paper is almost 15 years old now, so it may be a little bit different now, specifically if the MRI once again is performed before the biopsy. So we recently gathered a large series of patients with fulminant myocarditis. Was more than 400 patients here, 36 centers in 15 countries. Of these, a biopsy was performed in only 44% of the cases. And the myocarditis was proven by MRI in 29% and was only presumed in 27% of the patient. Those patients were very sick. They were all hospitalized in CCUs or ICUs. And mechanical circulatory support device was used in 77% of the patients. It was mostly VA ECMO, either alone or combined with the IBP or an impella. Some patients received only an IBP, 9% of these patients, and only 1% received an impella as a TCS support device. Overall, 35% of the patients died or needed a heart transplant or a LVAD at 1 year. And the death rate was 28% for these cohort of patients. When looking now at the severity, initial severity, there was a very good prognosis for those who never needed some kind of circulatory support device. 87% of those survived without a heart transplant or a VAD. It was 78 for those patients who got an IBP alone, and it was only 57 when those patients needed some kinds of advanced MCS support. Interesting data, there was no difference in the outcome of patients who did receive or did not receive a biopsy. It's, well, something we should explore now. Still, when looking at the timing of the biopsy, it was quite striking here. There was no major difference between those who did not receive a biopsy and those who got a very early biopsy within the first 2 days of ICU admission. But those who got a biopsy later on, the mortality was much higher, from 30 up to 51%, so much higher mortality. The type of myocarditis was mostly lymphocytic. 11% of the patients had eosinophilic or giant cell, and as expected, the mortality was much higher for patients with giant cell myocarditis. Those are the factors associated with mortality, transplant or a VAD on the whole cohort of patients, and as expected, age and severity of the disease at initial presentation, the renal score, higher lactate, the need for a support device were all associated with poorer outcomes, and the etiology of giant cell multiplied the mortality by 11 as compared to other patients. And we're focusing now on the group of patients who did receive those advanced support system. Again, giant cell was associated with higher rates of mortality, and together with lactate and the time from first symptoms to the TCS, and again, age as a factor of severity. So in conclusion, well, the biopsy is indicated in the most fulminant forms of myocarditis, acute cardiogenic shock. Its sensitivity will remain on the low side, probably because most frequently you will miss the area of inflammation. So how to improve? Those patients clearly cannot benefit from an MRI in the ICU, especially those who have a machine. And when to perform, so for sure each time there is an atypical presentation, and especially clinical presentation indicating sarcoidosis, giant cell, or other form of internal medicine, systemic inflammatory diseases. Thank you so much for listening.
Thank you very much. Are there any questions?
Question from the audience?
No questions? Professor Combes, I want to ask you something about the biopsy. Considering the novel imaging techniques and the low sensitivity of the method and the result of the trial that the mortality was similar between patients, that do you think it's really helpful, or in fact, how many times the method is helpful? What's your opinion?
So not that frequently. Actually, when looking at the time where it changed the way we treated the patients, it's probably less than half of the patients who got a biopsy for sure. And but there is a bias. Those patients who got a biopsy are not all comers. We perform a biopsy because, well, the presentation is unusual. Yeah. There is an eosinophilia in the blood, or There's some indication on the CT scan of sarcoidosis, for example, or whatever. And once again, when the presentation is atypical with heart blocks or recurrent VTVF, hard to control, those are situations in which the patient will get a biopsy very early. But you may miss it. We had a patient who got ECMO for 1 month. The first biopsy was performed after 10 days because there was no recovery. Biopsy was negative, and we repeated the biopsy at the time we have to switch from peripheral ECMO to central ECMO. We got a much bigger piece for analysis, and this time was positive for giant cell. Yes. And the initial presentation was quite typical of viral myocarditis. So, well, this is why probably some experts still advocate for systematic biopsy in every patient. But even though you perform a biopsy, you clearly may miss, because it's endomyocardial biopsy, and the foci just may be missed. And second, those foci are mostly located in the subepicardial wall of the ventricles, and you perform an endomyocardial biopsy. So it's another reason why you may actually miss the inflammation foci.
Thank you.
Thank you.
Thank you very much.
Okay. So next speaker, Michelle Chu from Linköping University Hospital, Sweden. Please, Michelle.
Thank you very much.
The floor is yours.
Thank you very much. So I've been asked to talk about post-operative myocardial injury, but I've actually taken the liberty to change the title to a perioperative myocardial injury. So I have 4 conflicts of interest and nothing related to this talk. So ever since the publication of the vision studies, let me just go back. Ever since the publication of the vision studies, the first vision study was published in Anesthesiology in 2014, myocardial injury that occurs during the perioperative period has been acknowledged to be a common complication after non-cardiac surgery. And this has been followed by other studies, including from our group, showing how commonly this diagnosis exists. So myocardial injury after non-cardiac surgery is now a well-acknowledged term. It's called MINS, but there is also something else called perioperative myocardial injury. And the reason why I'm bringing it up is because there are 2 different but completely related conditions. And in fact, they might even be the same condition. It's just that they're defined in different ways, and I'll tell you about it in a few minutes. But nevertheless, these are both previously unrecognized cardiovascular complications that occur commonly in about up to 20% of patients undergoing high-risk surgery. It doesn't require an ischemic feature. In fact, the majority of patients are asymptomatic. Up above 80-90% in our study, over 90% of our patients have been asymptomatic, and this is perhaps not surprising considering that postoperative patients quite often receive opioids or thoracic epidurals that mask their symptoms. So MINS, myocardial injury after non-cardiac surgery, is defined as an increase in cardiac troponins after surgery, whereas perioperative myocardial injury is defined as a perioperative increase, so an increase in the postoperative value compared to the preoperative value. The definitions, although in the literature has been interchangeable, the definitions are actually still quite unclear. The 4th universal definition of myocardial injury just simply defines it as an increase in high sensitivity troponin of over 99% of the upper reference limit in a normal healthy population. What we do know, however, is that the high sensitivity assays do identify more patients, but the cutoffs and the timings for when we should conduct these assays are still not well established. So in perioperative medicine, the most common way of assessing cardiovascular risk is to use the revised cardiac risk index. And this is a very, very simple scoring system. It's parsimonious. It only requires 6 factors, and you sum them up, and that will give you a risk predictive index for the occurrence of major cardiovascular events. Now, this is a scoring system that is 30 years old, and obviously a lot of things have changed with perioperative medicine. So the Canadian group, I'm so sorry about this. the Canadian group updated those risk predictive percentages in 2017, and this is the definition that we use today for the revised cardiac risk index. I'm not sure how many of you use this. This is only for the prediction of cardiovascular risk, not any other risk of complications, and doesn't predict mortality. Now, the problem with the revised cardiac risk index is, although it's very easy to use, the areas under the curve, so this discriminatory value of this index is only about 70 to 80%. And therefore, the European Society of Anesthesiology has suggested, at least within vascular surgery, where this index performs very poorly, that preoperative measurements of natriuretic peptides should be added, and this improves the discrimination of the revised cardiac risk index. So that was the ESA recommendation in 2019. Well, last year, the European Society of Cardiology updated the guidelines, and this is what it said. It's rather liberal, and it recommended active surveillance. So active surveillance with natriuretic peptides as well as cardiac troponins amongst all patients undergoing intermediate to high-risk surgery. Now, I'm not sure how many patients in your countries would be classified as intermediate to high-risk surgery, but certainly in Sweden, this would be about 400,000 to 500,000 patients every year that would have to undergo a preoperative as well as perioperative BNP and cardiac troponin testing. It also recommends that among patients where elevated NT-proBNPs are detected, as well as in patients that are symptomatic, for example with dyspnea, that a transthoracic echocardiography should be taken. So very, very liberal recommendations for cardiac biomarker testing amongst this group of patients that are about to undergo intermediate to high-risk surgery. I just want to show you this slide. This is a preview of the upcoming European Society of Anesthesia and Intensive Care Medicine focus guidelines on cardiac biomarkers. Now, these guidelines are a little bit more restrictive than the ESC 2022 guidelines and considers biomarker testing from 3 different perspectives. So firstly, from a prognostic perspective, and that answers the question of whether perioperative biomarker testing will be associated with specific outcomes. It also considers it from a predictive perspective, and that answers the question of whether or not the biomarker will improve the discrimination in order to stratify patients at risk. And finally, we asked whether or not a biomarker-enhanced strategy may improve management pathways. So considering preoperative, combined pre- and postoperative, or just postoperative troponin measurements, you will see that the recommendations are quite weak. So this is quite different from the ESC 2022 guidelines, although it's in the same direction. And you will see that the evidence grading is moderate at best and poor for many of the other recommendations. For risk prediction, surprisingly, despite the strong prognostic association of cardiac troponins and BNP with mortality, there is only a weak recommendation, and certainly for biomarker enhanced management, and by that I mean when you detect an increased level of cardiac troponins that would trigger a specific treatment pathway, there is no evidence. So just going through some of the studies that underpin that guideline. This is a Cochrane study looking at the prognostic as well as the predictive value of adding a biomarker to the revised cardiac risk index. So just to be very, very brief, the delta C statistic, so this is the area under the curve. It tells you about the predictive value of that biomarker to predict, in this case, major adverse cardiovascular events. So with NT-proBNP, preoperative testing will increase the predictive value when added onto the RCRI by 8%. When preoperative cardiac troponins were added onto the RCRI, it would increase the predictive value for the detection of major cardiovascular events by 14%, but there was really no benefit when both were taken. So the net reclassification index is another way of looking at it, and this really classifies patients to true positives or true negatives, and in this case, the NT-proBNP performed better than the cardiac troponins. So in this recent study, we showed that it wasn't just post-operative increases in cardiac troponins that were deleterious for mortality and major cardiovascular outcomes. We showed that preoperative increases, perioperative increases, as well as post-operative increases were all deleterious for health. We also identified a specific threshold, and that threshold was 14 nanograms per liter, increase in post-operative measurements compared to baseline measurements that were most predictive for poor outcomes. And that study was strengthened by this study from the Basel PMI group, showing how there is an exposure-dependent effect of troponin increases. So here you see this exposure-dependent effect. So the black line are the patients with no preoperative increases and no PMI. PMI, perioperative myocardial injury, an increase in the postoperative value compared to the preoperative value. So nothing has happened during surgery. Lowest risk, this is 365-day mortality. So the next level of risk, these are the patients with a normal preoperative TNT, but with a perioperative event. But look at this next group. This next group has had no perioperative event, but with preoperative increased TNT. And this is likely to represent a group of high-risk patients who may or may not be symptomatic and may be due to, let's say, chronic heart failure, atrial fibrillation, or even renal failure. And of course, the group with the highest risk are the group with preoperatively increased troponin as well as a perioperative event. So the question is, once we've detected that there is perioperative myocardial injury exists, can we do anything about it? And in fact, there is only one randomized controlled trial addressing this problem. So this is a managed study that randomized patients with myocardial injury after non-cardiac surgery. So it didn't consider the group of patients that had preoperative as well as perioperative changes, so only postoperative changes. And the patients were randomized to receive dabigatran, 110 milligrams twice daily after surgery. And it did indeed show a decrease in the risk of the primary outcome, which was major vascular complications, with no increase in major bleeding. And this is, of course, significant because these are patients that have undergone major non-cardiac surgery. Well, there were very many caveats to this trial, not least of which that the patients discontinued their drugs. About 42% of patients discontinued dabigatran before the trial ended. There are some studies indicating indirectly that there is evidence to put patients on aspirin or long-term statins, although these studies are just very well-adjusted observational studies, providing some sort of indirect evidence that patients suffering myocardial injury in the perioperative period should be given these drugs. So in summary, I just want to reaffirm that myocardial injury after non-cardiac surgery or during non-cardiac surgery is now an established complication. It's largely undetectable without troponin surveillance because these patients are asymptomatic. If you look for it, it will be there. There is still no consensus yet as to how myocardial injury that occurs in this period should be defined. Should it be defined as just solely as a postoperative phenomenon, or should we take in the preoperative and the perioperative cases as well? We know that all three elevation. So regardless of whether they're preoperative, perioperative, or postoperative, elevations are all prognostically important, but as I showed you, the predictive value is still not completely well established. Randomized controlled trials are still lacking. I only showed you one randomized controlled trial, and there's one more underway as I speak. And until those trials are available, I would suggest that we just do the simple but obvious things, the things that we do every single day as anaesthetists and intensivists. Avoid intraoperative hypotension, avoid perioperative anemia, avoid perioperative tachycardia and stress, judicious fluid use, and monitor your patients. Of course, report your results and audit them regularly. Thank you very much for listening.
Thank you. Wonderful lecture. Question from the audience?
No? Okay. Yes? Yes, you can ask.
I don't see.
Has beta blockers gone forever?
Well, you know, the POISE trial was a bit of a scare for the perioperative community. So the POISE trial conducted about 20 years ago, randomized patients to 200 milligrams of perioperative metoprolol with a start just prior to surgery. And indeed, it decreased the primary outcome, myocardial infarction and cardiac arrest. So it was a positive trial in that regard, but the cost was an increase in deaths and increase in debilitating strokes. So I do not think that perioperative beta blockers are gone forever. For patients who are already on beta blockers, you would continue them, and I think that is the recommendation, both of the ESC as well as the ESA, regarding starting perioperative beta blockers in a patient who has not been exposed to them before. I think the jury is still out. Probably 200 milligrams of metoprolol is a bit much, but we certainly do it in isolated cases.
Is there another question? Yes, please. Yes. Yes.
There are some studies done based on the Lees score, revised Lees score, and biomarkers. Do we have any evidence regarding the combination between NSQIP score and the biomarkers?
So do we have any evidence between the
association between NSQIP score.
The NSQIP score and the biomarkers.
In order to predict better the cardiac events.
Yes, that's a very good question. So NSQIP is the National Surgical Quality Improvement Program. It's a program run in North America, and they also have a score for risk. So the NSQIP score is not specific for cardiovascular risk. There is a specific risk, the Gupta score, that predicts myocardial injury and cardiac arrest, so not the other cardiovascular outcomes. Now, the problem with the NSQIP is it's kind of proprietary. It belongs to the American College of Surgeons. It's very, very well validated, but only in North America. So we cannot validate it outside of North America, and as far as I know, nobody has done a biomarker study added onto that score, so no. But if you have access to that proprietary...
And one question for me. We can have major risk surgeries and low risk patients, or we can have low risk surgeries and high risk patients. So do you think that there should be the combination major risk surgeries and high risk patients in order to consider biomarkers, or you think in all the combinations we should consider biomarkers?
Yeah, thank you. That's an excellent question, because of course, you have the patient risk and then you have the surgical risk, and quite often they go together. So the ESC 2022 guidelines actually makes that differentiation. They have a matrix where you have patient risk, 3 groups, low, intermediate, and high, and then surgical risk, low, intermediate, and high. But at the end of the day, the ESC 2022 guidelines recommended doing or using biomarkers in high-risk patients defined as those over 65 years of age or over 45 with any cardiovascular risk factor. As anaesthetists, we have some trouble with that because that would be 90% of at least the population that we operate on in my hospital.
Thank you. Thank you very much.
Thank you.
And the next speaker is Dr. Hannah Schaubroeck. She's from Belgium, and she will talk about the management of cardiorenal syndromes. Thank you.
Thank you. Good afternoon, everybody. I will just see if this works. Yes. So I added one word to my title, acute, instead of management of cardiorenal syndromes, because this topic is very broad, as you know. First of all, you know that the kidneys and the heart are heavily intertwined. The kidneys, they are aware or responsible for the water and the sodium balance in your body, and your heart, of course, is very important in terms of hemodynamics. On top of that, heart failure treatment has a very big influence on the kidneys, and as recently published in the 2021 guidelines, we have 4 cornerstones of acute heart failure treatment, or treatment that should be installed before the patient goes home again after his hospitalization with heart failure. And all these medications, except for the beta blocker, they have an effect on the kidney as well. So what is a cardiorenal syndrome? It was defined by Ronco in 2008 as a disorder of the heart and the kidneys whereby acute or chronic dysfunction in one organ causes acute or chronic dysfunction of the other. And we will focus today on the type 1 or the acute cardiorenal syndrome. So what is that? It can be an acute heart failure episode, which is complicated by AKI. It can be a cardiogenic shock, for example, due to an acute coronary syndrome. It can also be after cardiac surgery. So it is frequent, so it's relevant to talk about it. 47% of heart failure patients will also develop an acute kidney injury. 15% with an acute coronary syndrome will develop acute kidney injury, and also after cardiac surgery it is frequent. And it's also associated with an increased mortality. So we need to care about this problem. If we look at cardiogenic shock, which is the worst presentation of acute heart failure, it's normal that the mortality is even bigger. And when you have an AKI, this mortality goes up to 62% when you need dialysis. So I will focus mainly on the acute heart failure, which causes AKI, so the acute cardiorenal syndrome in the setting of acute heart failure. But still, we do have a lot of phases in acute heart failure. You can have a decompensated heart failure, which is the most frequent presentation in these patients. But you can also have a right ventricular failure. You can have pulmonary edema. So this is very heterogeneous. There are other factors that are influencing your image, which is the cause of this acute heart failure. Is there congestion or not? Is there hypoperfusion or not? Is it a preserved ejection fraction, a reduced ejection fraction? So a lot of factors that influence our management. When we look at the definition of the second organ that is involved in this syndrome, the kidney, we have to go back to the KDIGO guidelines of acute kidney injury. These definitions were already installed in 2012, but the question is, can we use this in our patient population with acute heart failure? When we look into the literature, mainly the term worsening renal function is used, and it's quite similar to KDIGO stage 1. So it's an increase in serum creatinine of 0.3 milligrams per deciliter, but still, if you look closely, there is a heterogeneity in definitions. So I'm not sure if we can use this terminology either. So how will we manage to define kidney function in acute heart failure? We can use a lot of markers, biomarkers in the blood or in the urine, but none of them have really proven their clinical benefit yet. But we have hopes that this will change in the future. So let's go to a patient admitted with acute decompensated heart failure. If you look at his serum creatinine, you will see that it was higher when he was not yet admitted in the hospital. He was congested because he had acute decompensated heart failure. So his serum creatinine went down, and then it fluctuated during your stay because of diuretic use, because of drugs you induced. So the question is here, what is the true baseline serum creatinine, and is there a true AKI or acute kidney injury in this patient? So it's complicated. Do we have a true or a pseudo worsening renal function? I would like to refer to this study to illustrate this. The group of Tastani, they looked at worsening renal function in patients with acute heart failure, and they used a biomarker of tubular injury. And they saw when you do a good decongestion of your patient with aggressive diuretic treatment, you will have no changes in tubular injury markers, but still you will have a change in your serum creatinine and your cystatin C. So, not every rise in serum creatinine means a true AKI in these patients. And you can divide the AKI in these patients into 4 categories. You can say it can be a functional AKI, so there is no harm to the kidney, but you see a rise in serum creatinine. Oh, no, wrong button. Here. So we can call this the pseudo-worsening renal function, or you can have a patient who has a rise in serum creatinine, but also a positive injury marker. And then we speak of a true worsening renal function or of a true acute kidney injury. I have to say that the subgroup of subclinical AKI is also relevant. These are patients that have a normal serum creatinine but still have some kidney damage, and they should be monitored closely because these patients can develop problems in the end. So why is this discussion in acute heart failure there? The main problem in acute heart failure is congestion. And we see that it's worse for prognosis than worsening renal function itself. So for example, in this study, it was shown that if you have worsening renal function and congestion, the red line, it's very bad for your survival. But if you look at patients who have worsening renal function without any form of congestion, it's the green line, they perform quite well. And they do better than patients who have no worsening renal function but who have congestion. So congestion is important. This brings me to the different mechanisms of AKI in acute heart failure. So there are a lot of hemodynamic changes in your patient that will cause the AKI to occur. One of these is a reduction in renal blood flow, but also an increased backward pressure or increased afterload of the kidney by a risen venous pressure in the kidney. And Mullins has nicely shown that central venous pressure correlates best with occurrence of worsening renal failure in these patients, and not cardiac index or other parameters. So another very important parameter in AKI in general, but mainly also in AKI caused by a cardiac cause, is the mean perfusion pressure. So the mean perfusion pressure is defined by the mean arterial pressure minus the central venous pressure. And this is nicely shown by one of my colleagues in the patients after cardiac surgery, that you have an inverse relationship between severe AKI and the mean perfusion pressure. Of course, not only hemodynamics play a role in development of AKI in the acute heart failure patients. You can have congestion, hypoperfusion, but you could also have an increased pressure in the abdomen, which can also cause an increased afterload for the kidney. You can have inflammation or a systemic inflammatory response syndrome. You can have thromboembolism. You can administer drugs that are toxic for the kidneys. And if you put your patient on mechanical support, it can also be bad for the kidneys when you develop hemolysis, for example. Kidney replacement therapy itself can cause hypotension during the therapy, can also induce more kidney injury. So there are a lot of factors that influence your kidneys. So, but let's go back to that patient. So he comes into the hospital with acute coronary syndrome and acute heart failure, and he develops a worsening of his renal function. What shall we do? What is for us the road to success? First question, is this a true cardiorenal syndrome? How we will define this? Let's do some other investigations. Is this patient hypovolemic? did he have diarrhea and he took all his diuretics? Could be the reason why he's now in an AKI. You should exclude that he has a post-renal AKI, so you should do an echo of his kidneys. You should perform a urine microscopy to see if there's no exotic nephrological cause of AKI, which should be excluded or treated. And if possible and everything is sorted out, you should try to get your patient on heart failure therapy as soon as possible. And of course, if you have really a problem with your kidneys, you should adjust the dose of your medication to the kidney function of your patient. Okay, secondly, perfusion is a very important parameter. You can evaluate this clinically. This patient is obviously not well perfused. You can also use invasive monitoring, but I think echocardiography has also a very important role here to assess your patient. And then if you have assessed perfusion stages, look at the things you can optimize. Can you stop blood pressure lowering agents? Do you need to install a vasopressor? Do you need to install inotropes? And mainly treat the underlying cause if you can. So if we go back to the lecture of Professor McLean with the Takotsubo cardiomyopathy, you can see that sometimes this can cause a left ventricular outflow obstruction. And if you restore the hemodynamics by just treating this left ventricular outflow obstruction, your acute kidney injury will be gone. You should also check your phenotype, etiology of your acute heart failure and treat it accordingly. Not every heart failure patient is the same. So a very important point in perfusion is to maintain this perfusion pressure, like we already talked about. And there are two main items you can do. You can either lower the CVP or higher the MAP, elevate the MAP. So to lower the CVP, sometimes vasodilators can be used. And of course, to raise MAP, you have a lot of products. But when you look at AKI, they are not well studied. So there is only one drug who has convincing results in terms of AKI after cardiac surgery, not in all forms of acute heart failure. And as levosimendan has shown in these meta-analysis, when you start it perioperatively, you can have less AKI. So the third thing you need to consider is congestion. Congestion is the main feature of most of our heart failure patients. So we need to treat this and we can evaluate this clinically, but we also need imaging for this. I think it's already mentioned before by Professor Mayo yesterday. Imaging with the VEXA score is really important to assess congestion. Look at the veins in your kidneys, in your liver, and then you will manage to assess this. You can also use biomarkers, but the studies in biomarkers are not well, don't have good results, so I can't recommend this really. And invasive monitoring, like a Swan-Ganz catheter, can be used if you're really in doubt how to manage the patient. So the mainstay for treating congestion are diuretics. Should be administered intravenously, and they can be administered continuously or in bolus. And you should assess your response to diuretic treatment. Another way to treat congestion is with vasodilators. We'll talk about this a bit later. And you can also use evacuation of third space fluids to help your patient. For example, if he has ascites, it can help your kidneys as well. And last but not least, ultrafiltration you can use as bailout. But if you think about congestion, we don't only think about fluid overload. So please be aware that it's sometimes just a misdistribution of your volume and not really overt fluid overload. So sometimes it's better to treat your patient with a venous and arterial vasodilator instead of a loop diuretic. So just consider this. But if you use an IV loop diuretic in a patient who is really volume overloaded, you can use a protocol. And I think it's good to have a protocol in your hospital to assess the response to diuretics and see if it's really working and if you're adequately decongesting your patient. And like I said before, the decongestion is for your prognosis a lot more important than the rise in serum creatinine. So what can you do to evaluate your response of your kidney at diuretic treatment? You can look at urinary sodium concentration, or you can look just at urinary output. We measure it anyway, so let's just see if it's enough. You should have at least 100 mils an hour during the first 6 hours after administration, but you should aim high enough. So if you have a patient on furosemide 40 milligrams a day, you might need 80 milligrams to start with to get this adequate decongestion. And if you're not managing with IV loop diuretics, you can add another diuretic treatment. As you know, we have a lot of places in our kidney where we can attack the sodium reabsorption. And a very recently studied was the ADVOR trial in 2022, which showed that acetazolamide, adding to the IV loop diuretic, has a very good effect on decongestion. Also, the IMPULSE trial about SGLT2 inhibitors in acute heart failure showed that they give a good decongestion of your patient, in addition to loop diuretics. And if this does not work, you always have a machine to help you. You can use ultrafiltration. And if you do that, please start low and go slow. I think this is the best way to go in these patients. There is not a lot of evidence to do this up front. So if you compare ultrafiltration with the standard stepped diuretic regimen, you better go for the stepped diuretic regimen and use ultrafiltration as bailout. Just a little word about cardiogenic shock. I talked a lot about the acute decompensated acute heart failure patient. Cardiogenic shock has a different presentation with hypoperfusion. Sometimes a lot of hits occur in these patients which cause this AKI, and these patients are more prone to kidney replacement therapy. 13% of these patients will end up at kidney replacement therapy. And you can imagine if you have a patient like this on all these machines, it's not unusual that there is also a renal replacement therapy machine involved. So this is my last slide. So what is the indication for renal replacement therapy in these patients? The classic indications exist, and you can remember this by remembering all the vowels you can see there. But maybe in CRS and cardiorenal syndrome, we should consider a lower threshold. For example, in patients who are very prone to fluid overload or very sensitive to fluid overload, such as patients with RV failure, patients who have already difficult ventilatory and oxygenatory conditions, or patients who develop anuria and you know they will not recover. So why wait a day? Why not start immediately to get that fluid balance right? So the management of acute cardiorenal syndrome is very simple. You should treat your acute heart failure as good as possible, and then your patient will do well and your kidney will also do well. So please think about other etiologies of AKI, treat reversible causes of your acute heart failure, maintain your perfusion pressure, and try to achieve adequate decongestion. And if you can, make sure the patient is on heart failure therapy, because this will get your patient better in the end. So with protecting the heart, we will protect the kidneys. And thank you for your attention.
Thank you, Anna. We have time for 2 questions. Question from the audience. May I ask something about renal replacement therapy? You have talked about perfusion. If your patient shows hypotension, do you prefer to start with vasopressor, or you prefer to support the kidney with replacement therapy? Because we know vasopressor can further worsen the situation of the kidney.
I think it really depends on your phenotype of your acute heart failure. If you have for example, a SIRS, you have a metabolic response, you probably need a vasopressor to get your patient better. And I don't think it's a good idea then to start right away with renal replacement therapy without treating the cause first. So I would say look at the cause of your problem and then decide what is the best way to go. RRT is just a way to support your patient, not a way to treat your patient. So I would say try first optimizing the patient and then you can go for RRT.
And the second question is about diuretics. If only the patient does not respond, but in KDIGO guidelines, diuretics are avoided to prevent a further damage in AKA. What do you think?
I think it really depends on your congestion state. If you have the feeling your patient, or you know because you do some examinations, that your patient is fluid overloaded, then you really need to get down on congestion, because it will also be good for your kidneys if your kidney is not congested anymore. So I would go for diuretics.
Thank you. Question? Okay.
Good question. I don't think the question was if your patient is on SGLT2 inhibition, should you continue it in intensive care? If your patient is not eating, I wouldn't do it anyway. If your patient is not hemodynamically stable, I would not do it either. But when your patient is stabilized, I would initiate it as soon as possible.
Yeah, we had several cases of euglemic ketoacidosis after.
Yes, it's a bit dangerous indeed to do that. Yeah.
Okay. Other question? Okay, thank you, Anna. We move to the next speakers. Professor Jan Belohlavek, when to use extracorporeal membrane oxygenation from University of Prague, please.
Thank you very much for inviting me to talk about ECMO and cardiogenic shock. I've got just one disclosure. I was an investigator of the ECMO CS trial. So why devices might be needed in cardiogenic shock or related occurrences? I'll show you something here. I hope we agree on that this is not a nice picture, and maybe we also agree on that it's cardiac arrest, isn't it? And maybe we also agree some of us would jump on the patient and start to do something. So hopefully it works. So the patient is patient who came to the cath lab with a STEMI and cardiogenic shock, was put on device and is still in cardiac arrest talking to us. And we just, what I did, I just waited. I completely disclosed. I just waited, wanted to see what happens, just preparing in case something happens. And it lasted 5 minutes like this, and basically nothing happened. So then we defibrillated the patient and continued the procedure, and everything was okay. So I don't need anything else to show that the device works. The device simply works, right? But the question is how to prove in the randomized trials that this actually helps the patients and improves the outcomes in the population of patients with cardiogenic shock. And there's been many trials. This is a Holger Thiele publication from 2019. You see many trials, and only those two, the landmark shock trial and the culprit shock trial, were actually positive. The shock trial showing that we should open with PTCA at that time, the occluded arteries in the STEMIs or acute coronary syndromes causing cardiogenic shock. And the culprit shock trial showing that if we open the artery, we should just stick on the culprit artery, not trying to fix all the other arteries which are involved in coronary disease. So, and that's it. No other study was positive so far. But we're going to have a lot of information very soon. I'll talk about our trial, which was published a couple of months ago in Circulation later on. Then within a month, the EuroShock trial, which enrolled only 32 patients, unfortunately, will be presented at the late-breaking trials at the EuroPCR. The ECLS shock trial by Holger Thiele will be presented at the late-breaking trials at the ESC in Amsterdam with 420 patients. And then the danger shock trial probably in 2024, and the anchor trial from Paris in 2024 to 2025. So within 2 years, it will be completely clear whether ECMO works or doesn't work in cardiogenic shock. But so far, until then, what is the current status in the guidelines? short-term mechanical support should be considered in patients with cardiogenic shock as a bridge to recovery or bridge to decision or bridge to bridge. So, of course, we use mechanical support devices in cardiogenic shock cases. And how we do that, we have basically two approaches. In cardiogenic shock, the standby approach or implantation approach. So standby approach means that if I got a risk patient in the cath lab, I just call the perfusionist. I have 24/7 assembled percutaneous valve, whether it's via ECMO or other, prepared, and then we usually secure the arterial access to femoral artery with a sheet, and we proceed with procedure. And if something happens and the patient deteriorates or crashes, it usually takes 5 minutes having perfusionist in the cath lab, drinking coffee, and then if something happens, he just stops or finishes fast, and then we proceed with implantation. It takes like 5 minutes if you are ready for that, so it's not a big delay. In those patients who are really without expected fast recovery, so you don't expect the effect of immediate PCI or a prompt improvement on catecholamines, we just implant immediately, and then we continue with the procedure. And there's been new indications for mechanical support, like unloading. I'm not going to talk about the ECPELA concept because Federico Pappalardo, as a guru of ECPELA, is here, so he's going to talk later on. And there's another extremely interesting indication for mechanical support, which is unloading strategy, DTU, unloading in large MRs, but this is not cardiogenic shock, this is out of scope of this talk. And in cardiac arrest, it's CCPR, it's kind of advanced club, and we're going to talk about that tomorrow. So cardiogenic shock is a very complex situation, and there's a great interplay of factors in cardiogenic shock. So there's a patient characteristic, comorbidities, body morphology, and the performance status. There is a cardiogenic shock phenotype, severity, the cause of the shock, the combined shock. The cardiogenic shock is never simple cardiogenic shock. Very fast it becomes the combined shock, usually distributive or septic, and sometimes patients do have a cardiac arrest before they develop cardiogenic shock. So the outcome of the patient is not just related to cardiogenic shock, but also to cardiac arrest. And then we have to look at the heart itself, whether it's just the left ventricle or the right ventricle or biventricle failure, what is the systolic and diastolic function, which both may play a major role. We have to look at the preload or afterload and optimize both of them. Preconditioning, we have to look to the valves, and of course to the chance of the recovery. And then we look at the treatment, so the timing on the treatment, the sequence of the treatment. We always discuss if a patient comes with a STEMI cardiogenic shock, should we implant the device before PCI or should we try PCI? And what do we do in case of successful PCR or vice versa, unsuccessful PCI? So it's extremely dependent also on the team and the operator experience and the case volume. And if we ask about the device and the kind of device we use, it's again about experience, expertise, a case volume, operator availability 24/7, which is our everyday problem, organization of the care, and resources and funding available in respective institution. And then when the patient moves to ICU, again, the medication, sedation, ventilation plays a role, complication management, resources, the number of nurses per patient, and again, experience and case volume. So you might agree that this is extremely heterogeneous population of patients, heterogeneous syndrome, and then no one-size-fits-all approach can be applied in cardiogenic shock. So let me give you two examples. This is a patient with anterior MI coming to the cath lab with a chest pain, typical setting, 70/50, defibrillated once for VF. And the patient has a very complex lesion, proximal LAD, left main. This is a culprit lesion. This is a sluggish flow in the LAD. And the patient was lucky, and the operator as well, the wiring the vessel and immediately dilating, implanting stent within like 12 minutes, and the patient is healthy. He's completely okay, improved immediately, leaves the cath lab and leaves the hospital within 3 days. Let me show you the similar patient here. This is another patient, again, anterior STEMI, again, very similar story. The only problem was early Monday morning, which is not a good time, 70/40, and you see sluggish flow here, and again, even the worst flow here. And right after this injection, the patient went into the cardiac arrest, and then you can see the typical pictures of the ECMO implantation during cardiac arrest and CPR and Lucas. So we did that. We defibrillated for his ventricular fibrillation. 9 times we managed to have the patient just sedated, not intubated, but the patient didn't recover. So this is the coronary angiography on VA ECMO. The ventricle is still fibrillating. You see this is ventricle fibrillation. This is not contracting ventricle. The LAD was fixed, but we were not able to recover the normal rhythm, so we vented this dilated ventricle with impella, and then the patient was converted to sinus rhythm and was transferred to ICU. You see the patient is on 2 devices. He's awake. He is spontaneously breathing. If you look carefully, he's just breathing. He's not completely happy, but he's alive after a very difficult situation and improves fast. And what is important to show is that this patient has a non-pulsatile flow. This is not an artifact. It's C93/88. It's completely non-pulsatile flow because the left ventricle is after such a severe damage. But he recovered ultimately and became very responsive. You see he's chatting with the family. This is an ECMO in the very final phase of the weaning. And then, before the ECMO extraction, intensivist decided to change his line. So he changed his center line, caused a massive hemothorax, hemorrhagic shock, and the patient died of multiple organ failure. So I'm demonstrating that this is a very, very complex syndrome. And to get a patient from the hospital home surviving, there's a lot of circumstances that actually influence the outcome of those patients. So what happens if we look at a cardiogenic shock population? We are aiming at optimal support. We are trying to prevent complications, and we are asking about the optimal timing of eventual device to use. And if you take a 50 to 60% of patients who survive anyway, and you implant those patients with device, you may harm them with many of complications. So those patients will survive well because they will go well through their cardiogenic shock. On the other side, there is patients who will do bad, whatever you do, even if you implant a device, because they will die of sepsis or neurological damage. And then there's the rest, this cohort B, which are those patients, and it's about 15 to 25, who might actually benefit from device if you use it. So therefore, this heterogeneity of the population means that a single intervention with device does not actually mean that the patient's going to do well. So what is the population? What is the device? And is the ECMO the right one? We know that the ECMO is a very good friend for circulation. It's a circulatory and respiratory support, but a very bad enemy for mainly left ventricle. It causes increased left ventricle afterload, left ventricle distension with enhanced filling pressures, may cause a pulmonary edema, increase of myocardial oxygen demand, of course, thus may worsen left ventricular recovery and may cause a fatal complications of LV thrombosis. And this is how, on a PV curve, what happens if you put a patient on cardiogenic shock on VA support and you increase the flow, you push the curve to the right, and you see the decreased ejection fraction, increased filling pressures, but also increased perfusion pressures, which is why we do that. And looking at this experimental work by Peter Stradal from Prague, showing that the increase of left ventricle and diastolic pressure in those animals which were subjected to increased flows of ECMO. So you see there is a very high left ventricle overload by ECMO. So based on all the information currently we have and looking at the SCAI definition of cardiogenic shock from the at-risk patients to very mild cardiogenic B to the classic, probably for classic patients, the Impella device, which provides plus minus 3 to 3.5 liters of the forward flow, and of course unloading of the ventricle, that would be the device of choice for deteriorating patients, probably via ECMO, and for those patients in extremis, combination of Impella would probably be the most. And this is what we thought until the publication came out from our group. It was a multi-center Czech trial comparing actually VA ECMO implantation in four institutions. in patients with rapidly deteriorating cardiogenic shock, so corresponding to SCAI D to E classification, or in patients with severe cardiogenic shock corresponding to SCAI D definition based on hemodynamics, so decreased forward cardiac flow, and metabolic definition, so increased lactates over 3, and of course avoidance of hypovolemia in those patients. And actually the patients were randomized to immediate ECMO implantation versus early conservative therapy with catecholamines and vasopressors with allowed downstream ECMO in the case of hemodynamic worsening, defined as the rise of lactate by 3 mmol per liter. And our primary endpoint was combined endpoint of death, resuscitated cardiac arrest, and implementation of our device. The population differs from other populations of cardiogenic shock. This is much, much more severe cardiogenic shock. You see their lactates were 5.3 versus 4.7. If you look back to Holger Thiele's studies, those patients had lactates over 2 mmol quite rarely, and 40% of those populations didn't have lactate over 2. So this is very severe cases. 50% of patients were on norepinephrine, and the average dose of norepinephrine was 0.5 mics per kilo per minute. So quite a high dose. And you see half of them was patients with acute STEMIs. And what happened? This is the conservative arm, and this is the ECMO arm. So no difference in 30-day mortality. And if we look at the primary composite endpoint, even no difference in the respective parts of the endpoint. Both death, resuscitated cardiac arrest, and another mechanical support was the only difference that 40 patients actually did get the device in the conservative arm. So, and there was no other difference in the respective groups. So let me conclude based on this that probably even in rapidly deteriorating and severe cardiogenic shock at the moment, we do have a time to try to stabilize patient with conservative vasopressors and catecholamines, and then if it doesn't work, use ECMO as a rescue therapy. Thank you for your attention.
And are there any questions? Yes, yes, please.
Just a moment, microphone.
I have a question. In the case of a severe aortic stenosis, yes, we had like for a few weeks an ECPR case. The patient was afterwards with a severe aortic stenosis with 0.4 or something like that, the square. That was pre-diagnosed, but we didn't know. But then we went in a situation where we had ECMO flow, but we had a complete impaired ventricle with stunning effect, with no opening of the aortic valve. We couldn't do any impeller device through the aortic stenosis, and my question is, would you consider acute valvuloplasty in that case, or what would you do?
Yes. Actually, in our ECPR trial, if you look carefully, we did have 3 cases like that. So undiagnosed aortic stenosis causing refractory cardiac arrest. We put on ECMO, then we diagnosed. But this is not easy to diagnose severe aortic stenosis in patients who have a standstill of the heart, because you cannot measure the gradient on the aortic valve. But anyway, we did do acute balloon valvuloplasty and then waited what happened. And those patients did quite well, actually. And the TAVI later on. It depends. You know, VA ECMO is a pretty good actually device to support aortic stenosis. So just you measure the pressures. In those our 3 cases we didn't put impella because some of them were you know, in the past. But I would just wait and look and then eventually put an impella if needed. But those ventricles are usually hypertrophic. They are not big, and they have a real, you know, good contractions if you avoid the severe stenosis. So usually they improve themselves very, very fast. We perfuse antegrade all the limbs if we cannulate ECMO. Which one? Oh yes, we use it if we don't have a femoral access. We can use axillary artery, of course. Yes, that's typical approach.
Hi, my question was to associate impella with the ECMO to offload the LV. Is there any evidence about that, of improving survival compared to only ECMO?
I think Federico is going to talk about that in his later trial.
Also,
Evidence is scarce, but there is some. Yeah.
The other question was about the PFO, because if you don't close the PFO, it might be at the beginning even beneficious because you can download the LV, but then once you are winning the ECMO and the right atrium pressure can increase, you can cause shunt. So do you normally close the PFO if you know that the patient has a PFO?
No, never in the acute setting. Actually, in those patients, PFO usually don't play the major role, but can be very helpful if you consider septostomy for unloading, so just in this case.
And can I ask you a question? Do you have a cutoff point for the age of the patients? It's 65 or 70 years old.
Yeah,
that's a
challenging question. It depends on the overall context, what happens with the patient. Yes, comorbidities, how the patient looks like, how was the performance of the patient before that happened. But, ECMO is our everyday practice. So that's such an easy intervention. It's not too expensive if you don't use the very fancy new devices. So, and compared to other care those patients are receiving, we usually don't hesitate too much to implant the ECMO at the beginning. And then we say, okay, the patient got a chance. And if something happens and the patient has a second hit, like a severe sepsis, multi-organ failures, then we don't continue and we stop with the first circuit. Yes. So we call it the first circuit chance. And if the patient doesn't recover on the first circuit, we never change the circuit.
Okay, thank you.
May I ask a question? It's a bit out of topic, but your opinion about severe myocardial dysfunction in septic shock with the left ejection fraction less than 20%. What do you prefer, a conservative approach or no?
I think you have to ask, you cannot leave the patient on a very low cardiac output status. So we have to do something. If catecholamines doesn't work, you have to put in ECMO, but ECMO will probably harm the left ventricle in this setting, so we can combine. And we have published in our group a case with a severe left ventricle dysfunction in a severe septic shock, which needed two ECMOs, two VA ECMOs together to generate extracorporeal flow of over 10 liters to support the circulation in a septic shock. So sometimes you just need to follow the physiology. If you have a severe sepsis with severe oxygen demand, you have to provide the flow, and you can provide the flow only by very high and very strong devices.
Okay, thank you.
There's one more question.
Yeah, question?
Last question, I think.
Yeah, last one.
It's no time.
Well, great presentation. Thank you very much also. I was wondering, in the last presentation, in the last study that you presented to us, ECMO versus conservative therapy, I saw that almost 50% of patients in cardiogenic shock had acute myocardial infarction. So ECMO itself works against the normal physiology of the heart. So increases afterload, increases oxygen consumption. Also, inotropes increases also oxygen consumption. So I was wondering, in this study, did you use or combine intra-aortic balloon pump with ECMO? Was there an arm of patients with these two characteristics to augment the flow from the left heart and alleviate the afterload in some way? Would that change the outcome?
In clinical medicine, not always the things work like you would expect, or like you would expect from the physiology. So we don't use balloon pumping routinely in patients with cardiogenic shock due to MI, because just the study didn't work. It was a very well-designed study by Holger Thiele, 2012, the balloon pump-induced shock study. But you are true that ECMO is basically not the first choice as a mechanical support at large MIs, because it makes a lot of harm to ischemic myocardium. So we are trying to avoid ECMO. ECMO is always our rescue therapy, and there is other devices which may help to unload the ventricle, but I would refer to following speakers. They are going to talk about that, I'm sure.
Thank you. Move to the next speaker, Susanna Price. from Royal Brompton Hospital in London, or other form of mechanical circulatory support? Please, Susanna Price.
Okay, apparently my presentation isn't there, which it should be. So do you want to go to the final one and I'll go back to the speaker thing?
Oh. You haven't...
No, you... What's happening?
Ah. She uploaded, but yeah.
Okay, never mind.
Okay, so we're going to talk about other support and not ECMO. I've got no conflicts related to this or any other presentation. So we've got a number of devices that we can use in cardiovascular critical care, and Jan has talked to you about ECMO, and you can see the connections there. What I'm going to touch on in this talk are the left-sided acute mechanical devices, not long-term ones, and a little bit on the right-sided devices. So we're just going to understand what they are, what they do to the cardiovascular system, and when they are used. So that's the focus of this talk. So first up, we'll talk about the left-sided devices, because I know that not everybody in the room will be super familiar with what we've got. One of them, though, you will know very well, the intra-aortic balloon pump. It comes in different sizes. It's usually femoral access, but you can use different types of access. It augments in diastole, and it has various physiological effects on the heart and the circulation. What it doesn't do, though, particularly, and some would say not at all, is increase cardiac output. The predominant effects are on end diastole and on coronary flow. So that's the intra-aortic balloon pump, been around for a long time. Next, you have the impeller device, or I should say family of devices. So the impeller device usually goes in through the femoral artery, but as Jan said, you can use different access points. It comes in different sizes, and it's advanced across the aortic valve, and it sucks blood from the left ventricle and delivers it continuously into the ascending aorta. So they're two very, very different devices that do different things. The impeller device is quite interesting. We've begun to study and understand what it does physiologically. So it will increase your flow, your cardiac output. It will increase your mean arterial pressure. And it does things to the left ventricle that may be potentially more favorable. So it drops your left ventricular end diastolic pressure. It drops your oxygen demand, and it drops your oxygen consumption. So in terms of an acute myocardial infarction, as some of the questions have been asked, it may be potentially favorable. It also does things to change the microvasculature, which are beginning to be understood, and we're also beginning to understand a little bit about what it does in terms of reperfusion after myocardial infarction. So it's a very, very interesting device physiologically. In terms of these devices and how they interact with the left ventricle, as Jan said, VA ECMO, very good for the rest of the body, not so good for the left ventricle. The intra-aortic balloon pump is somewhat favorable. It drops this pressure-volume relationship down to the left. The impeller, you can see, is even more favorable, and it changes the shape of it somewhat because you have some indistinct isovolumic contraction and relaxation phases. What that actually means to the heart, we don't know. And of course, a combination of two brings your pressure-volume relationship a little bit closer to what is slightly more favorable. The left-sided impeller, though, does not just affect the left heart. This is a nice study. It's an anterior myocardial infarction study undertaken in pigs. And they used left-sided impeller, and they looked at the pressure-volume relationships between the left ventricle and the right ventricle. And they showed, yes, of course, you get those beneficial effects on the left ventricle, but also some on the right ventricle. And if you add norepinephrine or noradrenaline to the mix, the right ventricular performance is even better. But when you look at the left ventricle, it comes at a cost, and it comes at a cost of increased stroke work. So the interventricular interplay with these devices is complex and not yet fully understood. So those are the left-sided devices. That's what they do to the circulation. What about when should we use them? So we've got 1 or 2 position papers, a little bit of guidelines, which I'm going to come to, and I'm going to talk to you about indications and benefits. So what's the evidence of what we've got, and what does our guidance say? So you remember Jan showed you the SKY classification for A, at-risk patients to E, in extremis patients. So that's the spectrum now of cardiogenic shock. And our interventional cardiology colleagues, you will see that they may have undertaken what they would call a high-risk intervention in the cath lab, and you may find a patient on an impeller device in your ICU afterwards. So you need to know why they're doing it and what may happen, and that you can look after these patients. They have a number of reasons that they may choose to use this device, sometimes because of the coronary anatomy, the left ventricular function. In some countries, patient preference, obviously not in my country, but certainly in the United States, that may be a driver. And there are several physiological or theoretical benefits that make it seem very attractive. The idea that you might intervene on a coronary artery and have no flow down the coronary artery and a combined cardiac arrest generally fills people with shock and horror. And you saw the potential benefit from the images and the videos that Jan showed you. The impeller is the only device so far to really be approved to support these high-risk interventions. The benefits, they speak for themselves, but there are significant downsides. So you need very skilled interventional cardiologists. There are complications associated with access and bleeding. There's not much data to support their use. And so our current recommendations are that for these patients, the impeller is the device of choice, and it's in certain highly selected patients by very, very expert cardiologists. So you may see that those at-risk patients may turn up in your intensive care unit on a device if it hasn't been removed at the end of the procedure. So that's the at-risk patients. What about the C, D, and E SKY patients, so the classical, deteriorating, and in extremis? And I'm just going to touch on either isolated balloon pump or impeller. So is there any evidence that one's better than the other? I'm going to touch briefly on LV unloading in ECMO as a warm-up to Federico, and I'll then talk you through the right-sided support we've got, and then just touch on cardiac arrest, because there's a little bit of data, but not so much. So in terms of when to use it, there are some hemodynamic considerations. So remember, the definition of cardiogenic shock has changed. It relates to hypoperfusion primarily, rather than hypotension. But we do still have hypotension in there, and we do still have a suboptimal cardiac index, and we can measure cardiac power output and LVEDP. So those are our hematological and clinical drivers. In our guidelines, there's a consideration that you should consider using these devices. It doesn't particularly tell you in detail, but I'll come back to it, which device you might want to use or when. And you'll see that the intra-aortic balloon pump is not routinely recommended in cardiogenic shock complicating acute myocardial infarction, because there was a randomized trial about 10 years or so ago now that showed no benefit. It doesn't show it's harmful, it just doesn't show benefit. So you don't recommend to use it routinely. So if we're thinking about the patient with cardiogenic shock, and you're thinking, should I use a balloon pump or should I use an impeller? One gives a bit more hemodynamic support, that's the impeller device. The balloon pump is quicker, cheaper, easier. So which one should I go for? We have some data, but not a lot of data. So this is from Benedict Schrager and his group. It's a matched analysis from IABP Shock 2, so that's the one that said don't use a balloon pump routinely in acute myocardial infarction, and it was matched with patients with impeller, and it showed no mortality benefit in this patient population. And then we've got a number of small other studies that again compare head-to-head patients who've had an intra-aortic balloon pump versus an impeller, not all randomized, or these aren't randomized. And the problem is when you drill down into the detail, although the hemodynamics are far superior when you use an impeller compared with an intra-aortic balloon pump in terms of cardiac output and index, pulmonary capillary wedge pressure, the complications from vascular access are a problem with these devices, which is why I say you need super skilled interventional cardiologists. This study is a randomized study. It compared patients with impeller and balloon pump and patients receiving PCI for STEMI, so it's a very specific group. And again, it showed no benefit of impeller. But again, going back to Jan's point, this is complex. 90% of these patients had had a cardiac arrest. And when you look at the cause of death, it was largely hypoxic brain injury. So we're using devices that may not actually fundamentally change what may kill the patient, which is the other organ dysfunction. So it's important to look carefully at the groups. But there is a big movement coming from North America. So the Detroit Cardiogenic Shock Initiative, which is spread wider now. Not randomized, but looking at highly protocolized, very selective use of the impeller in patients with acute myocardial infarction. And what they're doing in their registry is using impeller early, and they're combining it with very protocolized critical care interventions, including the use of pulmonary artery catheterization. So the question is it critical care plus cardiovascular intervention plus the device, or is it any one of those? And because it is registry data, we don't yet know. However, watch this space because some of our cardiovascular colleagues will be coming out with randomized data 2023, or I'm told possibly 2024. Okay, briefly just touching on unloading, there's been a lot of talk about the combination of ECMO and impeller, and I showed you the pressure volume loops to say it might be a good thing to do. A paper came out in 2022 looking at its registry data from ELSO, so it's not randomized, comparing impeller versus balloon pump, and it didn't show any difference in mortality, and in fact showed potentially again a signal for harm for the use of impeller. So we don't yet have the randomized data. And this paper in 2022 generated quite a lot of discussion in the American literature with a number of letters saying, well, we still don't know though which patients, we don't know which device, and we certainly don't know when we should be using this. Should it be early, should it be late? So the combination we don't know much about, and I'm sure Federico will tell us more. So those are your left-sided devices. You've heard from Jan about ECMO. I've told you about impeller and balloon pump. What about the right-sided devices? So we've got two groups. We've got direct RV bypass, and I would talk really through the impeller RP. So it's the same principle as the left-sided impeller. It goes up through the IVC, across the tricuspid valve, and then up into the pulmonary artery, and it provides direct right heart bypass, or the Protect Duo, which is like a very big pulmonary artery catheter that you can put an oxygenator in if you should need it. And then, of course, you've got indirect RV bypass with ECMO. So these do very interesting things to the right heart, so very nicely beneficial to the right heart. They'll drop your venous pressure, they'll increase flow through the pulmonary arteries, they'll reduce the pulse pressure, and you can see they significantly alter the pressure volume curves on both the left and the right heart. One thing you need to be careful with, in fact, both of the univentricular supports you may choose, is if you look at this right-sided device, what it will do is increase flow to the left heart in a failing right heart. And that may reveal what had been previously hidden left ventricular dysfunction. So if you're going to use either univentricular device, you need to look very carefully at the other ventricle, both before you use it and then afterwards. What are the recommendations? So again, back to our physiological, so signs of shock, and then some parameters that we use on the right side that may guide us. They've not been very well validated, but there are some indicators that the right heart may be in some difficulty hemodynamically. And then in terms of recommendations for which devices to use, they're very soft recommendations because, frankly, the data isn't there. So you can use the Protect Duo with or without the oxygenator, or the right-sided impeller. In the case of predominantly or isolated right ventricular dysfunction, the data come from serial cohort studies at best, and they've related to right ventricular infarction, pulmonary embolism, and the largest was the Recover Right study that looked at groups of patients receiving the right-sided impeller after, for example, cardiotomy or patients who'd received an LVAD, and it showed, compared with matched controls, an improvement in outcomes. Finally, then, cardiac arrest, very briefly. What do we have in cardiac arrest? So there's loads of small series. There are some registry data suggesting that maybe these devices are useful in a patient either with refractory cardiac arrest, post-cardiac arrest, or we did have with the SCI-A patients to prevent cardiac arrest. So these are after cardiac arrest. But in all of the ones that we've looked at, the usage of the mechanical circulatory support was relatively low. They're not randomized, And although the neurological outcomes were reported to be good, we don't really know the details of those studies. So there's a big international multi-center registry ongoing, looking at extracorporeal support after cardiac arrest. Again, it is a registry, but it's large, and we're looking forward to getting the data from that. So this is really just to summarize. The balloon pump we've had forever and a day, not recommended for routine use after acute myocardial infarction unless there's another reason to use it. The impeller, very promising, lovely hemodynamics, but a high complication profile. There's then potential use, so shock, so established shock, SCAI C to E, potential impeller use if it's predominantly left-sided failure. Combination use is interesting, and remember that processes and protocolized care seem to improve outcomes. And in cardiac arrest, potential role to prevent cardiac arrest, and then isolated left-sided support, post-cardiac arrest support, and potentially even in refractory cardiac arrest. So our guidelines, if I go right back to the details in the guidelines, are this. So you should consider using mechanical circulatory support acutely in a patient with cardiogenic shock, but depending on the gestalt of the whole patient. It's not just about the device, it's about the benefit to that individual. So you could use ECMO or impeller or right-sided device to keep the patient alive until the heart recovers, or to keep the patient alive and improve end organ perfusion in the patient's physiological status until you may be considering another longer-term device or potentially ultimately transplantation. And then, of course, for short-term in the cath lab for supporting a high-risk intervention. And at the end of it all, though, I put this as a big warning and a big caveat. We don't have the data to support the use of these patients. We don't have high-quality randomized data. And if IABP Shock 2 taught us anything, that if you go into a specific patient group and you're even expecting, because we all thought that balloon pumps work to save lives in patients with cardiogenic shock and acute MI, and they don't. So we have to be a little bit critical looking forward, and we're very grateful to the guys who are doing the studies that will inform us with randomized data. And I leave you the words with Ian Chalmers. So he was one of the co-founders of Cochrane, as in the Cochrane Reviews. And as he said, many interventions seem physiologically or intuitively sensible, but that doesn't mean that they're right. Thank you for your attention.
Thank you. Are there any questions from the audience? No questions?
Okay. Do you have any questions? No, particularly, we can move to the last lecture.
Yes, thank you. We have no questions. Thank you. Thank you very much. And the last speaker is Dr. Federico Pappalardo, who is going to talk about current strategies in mechanical circulatory support.
Thank you. Good afternoon, everyone. And I'm very happy to be here because it's very exciting for me to have such a full cardiogenic shock session in intensive care community. So this is going to be my very personal perspective to temporary MCS in cardiogenic shock. I will try to navigate you about a couple of things that I think are fundamental, especially in the light that I recognize this is an arena which is definitely calling for trials. So there is the wish to generate randomized controlled trials that give you a way to treat your patients. And as you know, there are trials which are being performed and which will be published shortly. So we know that ECLS shock trial will be reported in year 2023. Euroshock results will be reported in year 2023. Danger shock will be reported probably in year 2024. So this is going to generate evidence, and I think that beforehand it's important that we know how to leverage this data, but also to be able to navigate in clinical practice the evidence which is generated. I have a further disclosure. Besides these trials which are being performed in patients with acute cardiogenic shock, I am the principal investigator with Dr. Morishi of a randomized trial which is called the ALT-SHOCK trial, which is going to randomize patients who suffer from acute decompensation of chronic heart failure complicated with cardiogenic shock to medical treatment with inotropes versus a balloon pump. And I think this is very important because all the focus so far has been directed to STEMI patients, but data coming from the US and from our clinical practice tell us that the entity of acute decompensated heart failure is growing, and it's going to be even more significant in terms of incidence as compared to AMI patients. So you look at these data, and I want to call your attention to a couple of things which I think are fundamental in the field of randomized trials in cardiogenic shock. First of all, the enrollment criteria and the regulation which is behind randomizing a patient with, who is not able to provide informed consent across countries in Europe. So it's very important that this is to be thoroughly addressed, because you know that 50% of patients who will suffer from cardiogenic shock overall will have an episode of cardiac arrest. And the timeline of supporting a patient with cardiogenic shock is so quick, it's going so fast, that I can tell you it's very difficult. And if you don't have specific regulations, and the European community has provided just recently support for randomizing patients who are unable to provide informed consent, this is going to be a major challenge, because otherwise we are looking just at the best patients, so those who are awake. First of all. The second point is about enrolling patients who had cardiac arrest, because of course we can discuss about the value of mechanical support who is resuscitating organs, maybe the heart, but if you have anoxic brain injury, this is definitely going to drive all your outcome. So are these trials going to enroll patients who have cardiac arrest? Some of these are not, so patients will not be enrolled if there is any period of resuscitation. Others are going to enroll patients who had CPR, and they are using cutoff values for duration of CPR. But I think this is definitely very important, because receiving less than 30 minutes of CPR, it's really a long time of CPR. Receiving less than 45 minutes of CPR, it's a long time of CPR. This patient has been in cardiac arrest for a long period of time. So this is the first message. The second message, I think that you have captured the concept that the SCAI stages is nowadays the glossary or the nomenclature of cardiogenic shock. And this is giving us a great opportunity to speak the same language. When you are in a remote or spoke hospital and you are referring a patient to a hub center, just raise your phone and say, I have a SCAI-D patient. Go. Don't need any further information. So the SCAI classification is a fantastic tool to facilitate our work. And definitely it's a great tool to enroll patients in trials, because we are now far from the classic black or white definition of cardiogenic shock. Cardiogenic shock is a spectrum of disease. So it's I, A, B, C, D, and E. But look at this data. The definition of SCAI stages is different across trials and across physicians. So the patient A is SCAI-D for me and SCAI-E for my colleague. And this is captured by this data that we have reviewed from trials and registries which are published in the recent years. Just looking at SCAI-E, you recognize that SCAI-E is the patient who's trying to die, or you have to resuscitate. So as far as we agree in this room, this is the patient definitely for ECMO, so immediate biventricular support. Look at this data. The amount of patients who were on any kind of mechanical support in these studies in SCAI and who were staged E, it's not 100%. And then if you look at those mechanical support strategies still in these SCAI-E patients, not all patients received ECMO. So I think that still there is a lot to be done in terms of align with the nomenclature and the definition in terms of SCAI stages, which definitely it's a good opportunity. The other point is what is the value of the SCAI stage in clinical practice? So of course, when you are referring your patient to the hub, you can speak the SCAI stage language. So SCAI-E, immediate transfer. But what is the value of SCAI stages and temporary mechanical support to navigate in prognostication? Because the patient is SCAI C or D or E, but that does not mean that there is any value of the therapies that we are providing in terms of temporary mechanical support to those patients. So I think that looking back at this data, still from the ALT shock registry, which is an all-comers cardiogenic shock patients registry in Italy, we saw that the first 24 hours are crucial, fundamental to make the big impact of mechanical support in this patient's population. So when you use the metrics of mechanical support, you have to identify the hemodynamic platform which is able to reverse the hemodynamic status according to the SCAI stage. So you have to bring your patient back to a better SCAI stage, or to capture those patients who are deteriorating and who are admitted as SCAI C and will, in the next 24 hours, become SCAI D or E. How to do that? First of all, prognostication, as mentioned. The SCAI stage at 24 hours after admission is the prognosticator. It's not the SCAI stage as the patient is admitted, because there is no value of therapy. Thereafter, what do we know from this data that we have provided? First of all, the SCAI E patients. You can give an option to these patients with very aggressive mechanical support, but this mechanical support has to be able to bring back the patient away from SCAI E. If the patient is still in SCAI E stage after 24 hours of VA ECMO, this patient has a 100% chance of dying. The other point is to capture the patients who will worsen. And the patients who will worsen, in my view, are those who are apparently the healthier at the beginning, especially looking at SCAI B patients. SCAI B patients, which B is for beginning, or I would say the beginning of the end, as in our editorial, it means that you have apparently just a slight hypoperfusion, but in the next 50% of SCAI B patients will deteriorate. How to capture these patients? And this is your clinical practice, because these patients, I know that there are multiple parameters, markers that are used in clinical practice. These patients are captured by worsening lactates, increasing CVP, and worsening renal function. So just to give you an idea of which are the tools that you put in clinical practice to monitor these patients effectively in the early 24 hours. Then we go to what is my practice. So how I do see temporary mechanical support according to the SCAI stages, because we cannot think that with a single magic bullet we can hit and salvage all patients in every SCAI stage. Ultimately, we have to remind that the SCAI stage is a clinical picture, but this picture is built up with your clinical vision, but also some metrics which are defined by the hemodynamic parameters with the Schwann-Ganz, echocardiography, and labs. But according to each specific SCAI stage, there is a specific role of clinical values, PAC, echo, and labs. So this, and where it happens, so where is this cardiogenic shock patient, and so what is the story of this patient in terms of identifying and navigating through the hospital. So the SCAI A is typically a STEMI case with a huge myocardial infarction, but is in the cath lab, is stable. You won't do anything but an echo just to see that LV ejection fraction is depressed, do nothing. The SCAI B patient is a patient who's a STEMI patient in the cath lab, or you can have acute decompensation of heart failure. Usually this patient is more difficult to capture. That's why we are facing a lot of issues enrolling patients in this subgroup of population, usually in a normal cardiology ward or internal medicine, or in some institution in the CCU. You do echo, but you don't need a Schwann in this patient to stage or as SCAI B. And there might be someone who's still using the balloon pump in the cath lab for these patients. The SCAI C patient is typically a STEMI patient in the cath lab or in the ICU, in which you use the pulmonary artery catheter, which provides you data from hemodynamics. You use echocardiography to stratify this patient as SCAI C. you don't use the labs. So you don't have the opportunity you don't need the labs to stratify SCAI-C. These patients are usually treated with inotropes, Impella CP maybe, or Impella 5 or 5.5 according to specific issues. I don't think there is any typical patient who is in SCAI-C with the chronic heart failure. The SCAI-D patient is a STEMI patient or a chronic patient who presents either in the ICU, so this is the patient you will capture in your daily practice, or is a patient who's deteriorating from chronic heart failure everywhere in the hospital. So these patients are very much captured by the labs. So you have a patient who is apparently stable, you look at the labs, worsening renal function, worsening liver function, altered mental status. This is SCAI-D. And these patients, we do usually treat them with an Impella 5.5 or an Impella strategy according to the univentricular or biventricular dysfunction. The SCAI-E patients are everywhere. It's cardiac arrest. So patients who are under resuscitation, you can have arrest in the cath lab, OR, from the street, in the ICU. Every time you have an in-hospital cardiac arrest, I think it's a big failure because that means that you were not able to capture this patient earlier. So it ended up that you recognize this patient just when he was fibrillating. And this is the kind of patient you don't need echo, you don't need the pulmonary artery catheter, just implant an Impella with, an ECMO with an Impella venting. So my strategy in 2023 to manage cardiogenic shock is to identify, and describe according to SCAI stages. We do routinely use the pulmonary artery catheter, and I want to resuscitate in this community the value of CVP, CVP, CVP. Avoid exposure to inotropes. Mechanical support is to provide the patient weaning from toxics, so inotropes should be removed. Many patients will have an Impella first, especially CP, according to the data that have been previously described about the value of unloading in STEMI. It's, of course, fundamental that we are able to distinguish between univentricular and biventricular failure, to use Impella as a routine in my practice, but not because just of unloading, because it provides you the platform to de-escalate your patient. If you use an auxiliary strategy, you can ambulate your patient, the patient is awake, on left side, the isolated support, and you can take your time to take your decision and to see what is going to happen next in the field of decisions, recovery, bridge to durable LVAD or heart transplantation. And auxiliary strategies are definitely making a big difference in our clinical practice. Thanks for your attention.